So we'll start here. So we'll carry on from where we left off before. If you remember, the last case was this case. We had a study on 5/16/07. This was after the patient had surgery, and we can see that there's kind of a prominent black line across overlying the Hill-Sachs impaction injury. And if we go back and look at where it was before, you can see this was the Hill-Sachs, very large Hill-Sachs. When you do the calculations we talked about, it was an engaging lesion. And then now if we look at other images, this is what it looked like before. Little synovitis, very large capacious joint space back here. And now we can see a series of suture anchors along there where that capsule and tendon have really been tacked down to the bone, medial to the Hill-Sachs lesion, and that's the Remplissage procedure. And then that restricts the ability, the motion that you can do with the shoulder, so that you don't engage the Hill-Sachs lesion on the glenoid, and improves symptoms and decreases the risk of further damage.
Yeah, it eliminates the hole.
Yeah, right. Okay, now the other procedures that we hinted about before were the coracoid transfer procedures, of which there are a number. This is really a classic one where we can see metal artifact here, so we really don't see the anterior glenoid very well because it's obscured by metal artifact, but this is a very characteristic location. We can see that the coracoid process is a little bit deformed over here. We can see metal right in this location, and this is a Bristow procedure. John, do you want to tell us what a Bristow procedure is?
Sure. Originally, well, the procedure comes from South Africa. A student of Bristow's invented the procedure, or came up with it. And because he liked Dr. Bristow, his professor, so much, he named the procedure after his professor, and is known as Bristow. Initially, the procedure was not very impressive because all it did was you take down a piece of the coracoid process with the two tendons, biceps and coracobrachialis, and with the tendons through a hole in the capsule, you insert the piece of bone in front of the glenoid, and leave it that way without fixation and so on. And it did help more than 50% of people, so I guess they considered it successful. But then there were multiple changes into how this was done. And everybody liked the procedure because of the bony prominence that one puts in front of the glenoid and closes the hole, especially if there's 25% of the bone missing anteriorly. And with a screw fixes the coracoid process into the glenoid, and that closes that hole, and the head cannot come out. I play games with the procedure. I've done my share of these. I really kind of fell in love with it, and I modified it my own way and never wrote it up. I like the way I do mine, but I won't get into it right now. Then came along an individual called Ketojet. Ketojet is kind of an interesting name. I thought it was some kind of a device, but it's not. Who did not only the Bankart procedure, but also did the Bristow Ketojet procedure, what he called it. And basically, what he did was the Bristow procedure And then on top of that, he did to transfer the coracoid process and close the hole in front of the glenoid. That's a lot of surgery, by the way. He did the bank heart using arthroscopy, but Bristow, you cannot do it arthroscopically, to my knowledge, and he did that open. And that's an awful lot of surgery. I probably should have published some of my results. I had a good number of these, and only had one recurrence, and it was a guy that was a dope addict and spent a lot of time in jail, and happened to be a neighbor of mine down the street, whose sister worked for me, and I sent to school because her mother was wealthy, but wouldn't pay for her school. She gave it to her church. Anyway, this was my only recurrence. He was out there scuba diving or no, riding a board, and he fell and with outstretched arm, and then we dislocated. And that was the only case that I've ever had that broke down the Bristow procedure out of about maybe 40 cases or so, which in my time was a lot. Now guys do up to 200 or so in their careers, and that's something we never did in my day. People were a little maybe more conservative in that regard. So that's a long explanation, but that's how it was.
John, could you explain the difference between a Bristow and a letter J?
Bristow, a letter J is basically the same thing. The letter J is just the way he did the Bristow.
Yeah, they just turned it on its side rather than the N.
Right, and then also did the arthroscopy.
Yeah. Okay, so this is.
There are many ways to do the Bristow. What I used to do is I used to incise on the subscapularis longitudinally, a little lower than the equator, and then transversely, and I had a nice opening for the coracoid process, and I pre-drilled it, and then I put a screw in it and removed the screw a little bit, and then did an osteotomy, and I had myself a nice piece of bone with that screw already inserted. Good. And I only had one break, and that was done by a resident. But I tied it up with the sutures, and it worked just fine. So is the way he did the Bristow procedure. He did it transversely through the subscapularis. He didn't imbricate it like I did, tighten it up. What he did was just a lateral incision and split the subscap down to the capsule, and then inserted the bone. I used the Bosworth screw, which had a very large head. He used apparently a regular screw, which doesn't give you much of a purchase, because you need a pretty good sized thread. You need Cancel's bone thread, which Bosworth has. And we'll talk about that when we talk about the AC joint.
Good. Thanks, John. Appreciate it.
You bet.
So this is basically the preferred procedure for most people who have a lot of bone loss anteriorly. Bristow, the letter J, you just turn the coracoid on its side, which makes for a little bit more congruence with the articular surface and kind of a little bit better filling factor of the bone defect, but it's essentially the same procedure, which is a coracoid transfer. Okay, and then now let's go on to look at what can happen in the posterior aspect of the greater tuberosity. Typically, three things happen in the area where you get a Hill-Sachs fracture. You can get the Hill-Sachs, you can get erosions from infraspinatus insertions, which we see on most adult patients at just varying degrees due to chronic traction injury of the bone there. And then for overhead throwing athletes, this is the same area where you get posterior impingement or internal impingement from impaction of the posterior superior aspect of the humeral head against the posterior superior glenoid in the late cocking phase of the throwing motion. So here's what
John, I'm sorry to interrupt you. With a coracoid, you do with it what you have to work with. It's not a structure that you can do different, the same one 100 different way, 100 different times. It's different every time you do the procedure. The coracoid process has all kinds of appearances when you look at it clinically. So you can't play games with it, otherwise you'll break it, and you can't twist it around too much. You just be gentle, and then you make it as a block so that the head cannot come out. That's all there is to it.
Good.
It's just nothing, no big deal.
Okay. Thank you, John. So here's a typical Hill-Sachs injury that we've seen. It typically has this V-shaped type appearance. Here we don't see a lot of bone marrow edema around it, so this is probably not acute, probably more of a chronic one, though we see some little cystic changes here in that area. This is follow-up about 9 months later, and we can see that maybe this was subacute or something. It's a little bit irregular. Now it's smoother, and we can see the cystic change has resolved. So, but that's a typical variant of kind of a subacute and a chronic type Hill-Sachs injury. Here's another abnormality in that same area. There we can see this has a little bit different configuration. This is more kind of a cystic appearance rather than the V-shaped appearance that we see here. So if we go back here, that's kind of the typical appearance of a Hill-Sachs. This is more of a cystic change compatible with traction injury at the infraspinatus insertion. And in this particular case, the anterior labrum looks normal.
Is that John, due to loss of bone?
This is due to traction
or pressure.
It's due to a traction injury from the tendon where you get trabecular fractures, subchondral bone. The bone tries to heal it, and if you have ongoing traction trauma, what you get is a lot of the trabecular will stay fractured, they get resorbed, and you get these little geodes, and then you get thickened trabecular bone around it, so it ends up with a geode or a cyst.
Like the greater tuberosity area.
Yeah, right. In this particular patient, however, a little bit higher up, we can see marked truncation of the anterior labrum. And we go down, we can see a torn inferior labrum here. And this was a patient, this is a traction cyst. This is actually the Hill-Sachs injury associated with the anterior labral tear. Here's a shortstop playing, also has an injury to the bone in that same location. This one doesn't have the typical V shape that we see. We can see that there's a lot of tendinopathy of the infraspinatus tendon at the insertion here. Really looks like little cysts, subcortical cysts here. So this again looks like a traction injury rather than a typical Hill-Sachs, which we can see in this location. And this was an infraspinatus erosion. This one could be either due to internal impingement or a traction injury of the infraspinatus, or a little bit of both, since this was a high-level baseball player. And the shortstops do a lot of throwing because they have that throw to first base and the throw to home plate. So this was probably a little bit of both traction injury as well as internal impingement in this patient. Here's a patient where we can see a large cyst in this same location. This doesn't have the V-shaped appearance of a Hill-Sachs. This is more like a big geode underlying it. This is more of a chronic traction injury at the infraspinatus insertion. And we've already seen this image. This is a posterior cuff fraying. This is an impaction injury here. This patient, this was a loose body, but this patient didn't have anterior instability. This was a professional baseball pitcher, and this was someone who had posterior or internal impingement with repetitive impaction injury of this posterior superior aspect of the greater tuberosity right next to the infraspinatus insertion in the cocking phase of throwing. So when you see pathology in that location, those are the three things to look at. If the patient is not a high-level overhead throwing athlete or a fairly teenage pitcher in little leagues, then you could pretty much forget about the internal impingement and just think about whether it's a Hill-Sachs or a traction injury from the infraspinatus. And typically the Hill-Sachs will have that characteristic V-shaped appearance. So let's go on and look at other labral tears. We've looked about anterior labral tears. Let's go and look at posterior labral tears. These can occur from posterior dislocation. When you get posterior injury to the labrum, you can get calcification, and you can also get the displacement like we saw in MLB lesion and thickening of the periosteum. And this will typically calcify over time. And when it calcifies, it ends up with what's called a Bennett lesion. There's another lesion here that you can have, which we'll talk about, which is the GL lesion, which is the posterior inferior aspect of the labrum. And this is really where you damage the labrum so that it no longer has good mechanical integrity, and it just becomes blunted and not firm and allows posterior interior subluxation of the humeral head. But you don't see a discrete tear. And these also are fixed in the same way as if it were a tear. But we'll talk about the GL lesions as well. Okay, Ashley, what do you think of this case?
So patients fall while saving a Picasso from dropping in Malaysia.
The history is the best part of this case.
I know. That's great. Just looking here. Don't really see much. Is there some separation there?
Well, what you see is an overlap between the glenoid, posterior glenoid, and the humeral head. And then it looks like you've got this double line sign here, like there's an abnormal trough in the humeral head.
Okay.
There's the Y view. What do you see with the Y view?
Looks like it's posteriorly subluxed / dislocated there.
Okay, and this is the MR view.
Okay, and there you can see the almost complete posterior dislocation and marrow edema of that humeral head, as well as impaction injury onto the glenoid. And it looks like the posterior labrum is gone.
Yeah.
Torn.
So this is a
displaced inferiorly.
This is a reverse Hill-Sachs, same mechanism of injury as a real Hill-Sachs, except this is posterior displacement, not anterior displacement. So we can see a nice mechanism of injury here. And here on the coronal planes, this is kind of that area of impaction that we could see on the plane films. Here's the T1 weighted image showing a lesser tuberosity Hill-Sachs. And this is a patient who had a posterior dislocation. At least he saved the Picasso. Jennifer, what do you think of this case?
Hello. So here it looks like there's significant posterior subluxation of the humeral head with respect to the glenoid. And just on this single axial image only, the glenoid looks retroverted and diminutive, like this may be congenital dysplasia of the glenoid.
Okay, here's the MR.
So here again, we can see posterior subluxation of the humeral head with respect to the glenoid and diminutive appearing and retroverted glenoid. So this is compatible with congenital dysplasia.
I would call this a dislocation.
Yeah.
Oh, well, there it is.
Yeah.
Yeah.
So John,
Yeah, subluxation would be maybe a partial movement of the head away from the glenoid, but this is a complete movement of the head.
right. So John, you want to say anything about young kids with this kind of instability? John?
I'm sorry, I didn't punch the. This is more likely due to epilepsy and severe convulsion disorder. That's what my history of this condition
Good.
tells me.
Great.
And trauma usually doesn't do this. That's pretty rare. Like the most common fracture in sport. What sport, Jennifer, would you say the fracture of the glenoid occurs with a dislocation?
Well, I know overhead throwing athletes can be predisposed to posterior impingement. I'm not sure about dislocation.
It's usually caused by rugby. A lot of literature comes from that part of the world, like South Africa and Australia and Britain and places like that. If you want to read about that condition elsewhere. In fact, Jack, does he come from there, John? I don't know this guy.
Who?
Jet.
I don't know. I don't know where he comes from.
I think he comes from Australia, not Australia, but South Africa.
Okay. Good. Okay, Ashu, what do you think? I mean, Michael, what do you think of this one?
Okay, so first thing I notice is the humeral head is, posterior sublux, and it looks like there's a impaction fracture kind of along the, almost like the medial aspect of the humeral head in a way. And it looks like it's kind of locked on with the glenoid.
Okay, so this is again a posterior dislocation with a reverse Hill-Sachs.
Mm-hmm.
See a lot of edema here. And the
yeah, there's muscular edema on the rotator cuff.
Yeah. Okay, so this is 6/28/06, and now the patient's this is 7/1/06, so a few days later.
Okay, so now the humeral head is kind of back in. It's still a little somewhat posterior sublux, but it's not completely dislocated. We see the anterior, kind of the reverse Hill-Sachs impaction fracture. And then there's a little bit of low signal right there where you're circling. And it looks like there might be, I don't know if that's what that is, if that's a piece of cartilage or.
Yeah, I'm not sure either. It may be a little synovium or something. But this is just a reverse Hill-Sachs.
Mm-hmm.
Are we going to go into treatment later, John?
Sure, go ahead. Go for it right now.
These break down if you cannot correct the seizures, and they will break down any repair that you use, and so ergo a bone block is usually used, and you also change the tendon structure around the head, so that the tendons don't pull the head out of place.
Sure.
It's rather complicated to try to explain it, and I haven't done too many of these.
Great, thanks, John. So here's a 22-year-old male athlete. This one did not have seizures. This was an injury. Let's see, Jennifer, is this your turn?
Yes, It is. So here we can see some edema-like marrow signal intensity along the anterior inferior humeral head, compatible with the reverse Hill-Sachs lesion. And there's also increased signal intensity along the posterior labrum at the chondrolabral junction. That looks like a reverse Bankart injury. I can't tell if there's an osseous avulsion fragment.
Yeah, I think this is just a posterior labral tear. And then you can see there's also a tear of the anterior capsular structure here. This happens to be the middle glenohumeral ligament, which is also torn in this case. So we can see those three injuries, and this was from a direct blow anteriorly, which caused a posterior dislocation. Okay.
Is that with weights, John?
No, this was actually, he was hit during athletic activity. This wasn't with...
Oh, with a shoulder in football, probably.
Yeah, right. But it could occur with bench pressing. Okay, a subtle case here, Michael.
I think we skipped my turn here. Maybe.
Okay, then why don't you go for it, Ashu?
All right then.
Well, patient had trauma 2 months ago, and it's obviously a non-union comminuted fracture of the humeral head here, and it looks like it's broken half and it's subluxed, and doesn't look like it's ever going to heal.
Yeah. So this was just a big comminuted fracture and a posterior dislocation in this patient.
Is that reverse Hill-Sachs just extending all the way? Would you call that a reverse Hill-Sachs, or would you just call it?
And this one I would just call it a comminuted fracture.
Okay.
Just grab the locations, and then you can see the posterior dislocation.
Yeah, you start thinking about the total replacement.
Okay. Michael, what do you think of this one?
Okay, so we see a small impaction fracture with some marrow edema anteriorly, and then we see a big labral defect, posterior glenoid defect. It just looks like a, I don't know if that's just periosteal stripping, like kind of like a reverse, pulpsa or reverse Perthes type labral tear.
Except it's torn here, so this would just be.
It's a posterior displacement.
Yeah. Okay. So this is a posterior dislocation with reverse Hill-Sachs and a posterior labral tear, and probably a little bit of a
cartilage defect.
Cartilage defect as well. Good. And then I don't know. This is a patient who had a posterior dislocation and some edema here. Oh, that's right. This is a good case. Jennifer, what do you think of this case? Patient has known recent posterior dislocation.
All right, so we had talked about some edema in the deltoid, and it looks also as though there's some edema in the teres minor. So I'd be concerned about some type of denervation injury. I'd want to evaluate the labrum and see if there are any paralabral cysts, and then also if there could be any nerve damage.
Yeah, and notice here that this patient has had an anterior labral repair here and has a deformed anterior glenoid. So this patient has probably had anterior dislocations in the past too. So he probably has multidirectional instability, and this is a neuropraxis due probably from stretching of the nerves of the at the time of the dislocation. So something else you need to look for.
Makes you think of a motorcycle again.
Yeah. And here's another posterior labral tear, another posterior labral tear. And let's see here you can see a posterior labral tear here, plus a posterior capsular tear in through here, which is subacute. Okay, Ashley, what do you think of this one?
So a 19-year-old with recurrent dislocation and multidirectional instability, no trauma. Looks like there's an arrowhead between the labrum and the periosteum, almost like looks like there's, but the labrum looks intact. I think this looks like the capsule. This looks like a redundant capsule there.
Yeah, well, yeah, it's probably a labral tear here with some fluid coming out here. And,
Okay.
And probably the periosteal attachment is still intact. So this is probably a Popsicle lesion, and the tear probably goes right through here. And we remember the Popsicle lesion in front, and here's the periosteal attachment. And here's just some kind of appearance in the literature of these labor. Again, as we talked about before, and John talked about also, that this periosteal attachment is not really important from a clinical standpoint. And so why it's really named, I don't know. But anyway, you can just describe this as a posterior labral tear with an intact periosteal attachment. And then this is just from David Stoller's book, where you can see a typical Bankart anteriorly, an Alps lesion with displacement of the anterior labrum, and then it adheses to the bone up here in the periosteum. Perthes lesion, where the periosteum is still intact, a reverse Bankart lesion, and a Popsicle lesion is just basically a Perthes lesion in the posterior aspect of the labrum. Okay, Michael, what do you think of this one?
Okay, so the posterior labrum is torn with really thickened, it's probably kind of older, thickened periosteum that's kind of scarring.
Okay, so we have posterior labral tear. So this would really be a Popsicle lesion.
That's
significant.
Yeah, that's chronic.
Yeah, and this is
repetitive.
Yeah, this is a different patient, but it's the same kind of lesion on plain films. What do you see here?
Are we seeing like a little bit of bony protuberance along the glenoid? So it'd be at a Bennett lesion.
Yeah, so this is a Bennett lesion, and this is really calcification of that posterior labrum and periosteal attachment. And as John just said, this is really typically involved in the recurrent chronic injuries, and the body tries to heal it, and you get calcification in the area of the lesion. And this used to be the only finding we had back in the plain film days as a chronic lesion. And this particular patient, a little different from the other one you had, but you still see the periosteal attachment. Here it's markedly thickened, and here you've got a little bit of increased signal intensity within it, even though this is calcified. So that's really what a Bennett lesion looks like on plain films, and this is that lesion as it looks on the MR examination. So this is just a calcified Popsicle lesion, Bennett lesion. Okay, and here's another patient who had posterior calcifications on X-ray, and this is another posterior labral tear with thickening of the periosteal attachment, so it's another Bennett lesion. Okay, Jennifer, what do you think of this case?
So here we can see that these are axial shoulder arthrogram images, and we can see some mild irregularity and intermediate signal intensity along the posterior labrum, but I don't see full thickness enhancing tear at the chondrolabral junction. So this may be just some softening or prior injury of the posterior labrum. This could be a Kim's lesion.
Yeah, well, let's look at some other aspects here. Here's a X-ray. You know, there's some funny little calcifications here. Here's a CT scan.
Okay, so here we can see some calcification along the posterior labrum. So this would be another Bennett lesion.
If we go back here, this is the MR scan, and you can see you just don't see that very well. This is actually calcium here, and this is some stripping, periosteal stripping here posteriorly. So this is this patient has a chronic posterior labral injury with calcification. So this is really a Bennett lesion, but it can be subtle on MR, subtle on X-ray, and easily visualized on CT scan. And there we can see that calcification of the periosteal attachment of the labrum. So this is a Bennett lesion. Okay. Ashley, what do you think of this case?
Okay, 18-year-old male with instability with 2 axial sequences here. There's irregularity of that posterior labrum. I think it looks like it's disrupted, and I think there's a periosteal stripping there.
Yeah, so it's torn. So you have a posterior labral tear with, I agree, some periosteum here. Here's what the sagittal images looks like right in through here.
It looks a little thickened there. Yeah, and that looks like another Bennett.
Yeah. So here's another Bennett lesion in an 18-year-old, and you can see all the calcification and the disruption posteriorly here. And this patient is at risk for this because they have a retroversion of the glenoid, which makes them susceptible to posterior instability. So retroversion is a bad thing to have if you're an overhead throwing athlete, because this posterior, especially the posterior superior aspect of the glenoid, is very important in the throwing athlete, as we've already heard. And if it's not well developed, these patients tend to get unstable shoulders. And that's another Bennett lesion. Okay. Michael, 20-year-old female.
Okay, so rule out labral tear. So portions of the labrum I think I am seeing are, I don't know, maybe along the inferior glenoid.
Okay, so right in through here, notice that it looks like that inferior glenoid is not really very well developed.
Yeah.
It's kind of flat.
Exactly.
And if we go to the axial images, this is the area we're concerned about right back here. And again, you don't have good prominence of that posterior inferior glenoid in that location. And maybe a little signal change here of the labrum, and not really a very sharp. And notice also that you have some periosteal thickening here at the labral attachment. And so this is, but the surface looks nice and smooth, which is what it looks like also at arthroscopy. And this is the classic appearance of a Kim lesion.
Okay.
And incomplete avulsion, probably associated with some degree of either failure to develop of the posterior inferior glenoid or prior injury to the posterior inferior glenoid. And at surgery, it's kind of softened, and it's not firm, and therefore it does not act as a good bumper for the humeral head in that posterior inferior area. And for unstable athletes, it needs to be freed up and repaired like you would a labral tear. Here's another. Here we can see a posterior inferior labral tear. A lot of thickening here. See a lot of irregularity of the surface, but at arthroscopy the surface was still intact. But you can see a lot of injury to the labrum below the surface, which is where these are. And that's a Kim lesion. This patient had instability. Okay, Jennifer.
So here we have some axial images of the shoulder, and there's some edema in the posterior glenoid and some irregularity of the posterior labrum, which also appears slightly hypertrophied. I don't see definite tear at the chondrolabral junction. I'm wondering maybe this could be another Kim's lesion.
And we can see that posterior glenoid looks like it's just either kind of impacted or it's really not normal. So it looks like this may not allow good stability for the humeral head. And then if you look, the humeral head center is posteriorly. So there's a little bit of posterior subluxation of the humeral head and an abnormality of that posterior glenoid. which we see right in through there. And then we can see on other images, we can see a posterior labral tear with fluid extending in that particular area. And this was a posterior labral tear, but kind of a Kim lesion as well, though this patient had an actual tear, in addition to probable insufficiency of the posterior inferior labral rim. And so this is basically a situation where the labrum becomes deformed and loses its mechanical integrity, allowing easy posterior inferior instability of the humeral head. And it's typically thought to be due to repetitive trauma. And arthroscopically, you can see that there's nothing keeping the probe from just sliding off the posterior inferior rim into a very softened and deformable labrum. And here's a posterior labral tear, which we can see there. And again, fluid going through the posterior labral tear in this other patient. All right, Ashley, what do you think of this case?
Okay, so 42-year-old male with bilateral shoulder pain 1 week after bungee jumping. First thing I noticed here is I think there might be capsular disruption inferiorly. Right there, yeah, it doesn't look like there's a good humeral attachment, and there's fluid extending beyond the capsule there. And there's quite a bit of edema and a fracture of the humeral head.
Yeah, so a accommodated fracture of the greater tuberosity there. And here you can see where it's really probably an avulsion fracture at the rotator cuff insertion. This is just a kind of a picture of bungee jumping, and as it went down, and just a lot of tension on the arms caused this to fracture. So bungee jumping, common injuries for those of you who are big bungee jumpers. Watch out for your eyes. You don't want them to bulge out. You can get back injuries, perineal palsies, intracranial hemorrhage, death, which is not a happy result, but the shoulder injuries haven't been well reported. Okay.
Is death injury? I didn't know that was a.
What? Okay. Michael.
Oh, I was saying I didn't know death was considered a specific injury.
Yeah, that's a major injury. Okay. What do you think of this one, Michael?
Okay, so 24-year-old Major League Baseball pitcher, nucleation, history of labral tear. So we can see some suture anchors in the posterior labrum. There's kind of increased signal at the glenoid labral interface. It's pretty thickened, all the soft tissues there. So I'm assuming there's probably a re-tear of the posterior labrum.
So this is
and now we're doing kind of an Aber view, and you see that linear signal at the interface again. Yeah, where the arrow is.
And then what do we see here?
I mean, he's got, posterior subluxation of the humeral head as well, and there's kind of maceration or diminutive appearance to that posterior labrum.
Yeah, so this patient
there's gonna have posterior instability.
This patient has.
Oh, and then he also has like a Hill-Sachs. Is that a? No, that's probably just a cut.
So this is multidirectional instability with a Hill-Sachs impaction
Anterior
with an anterior labral tear, and then also a posterior labral tear here, and probably a retroversion of the glenoid, with probably a congenitally large posterior labrum. So this patient is very unstable.
Probably falls into the looser category in my scale.
Jennifer, what do you think of this one? Jennifer?
Sorry about that. So here we can see increased signal intensity with contrast along the posterior labrum at the chondrolabral junction, compatible with a tear of the posterior labrum. There's also some increased signal in the subscapularis, although that may be related to injection.
Yeah. Why do you think this patient developed the posterior labral tear?
It looks like there's a somewhat retroverted appearance of the glenoid.
Yeah, I think it's severe. This is an axial image. So you have severe retroversion of the glenoid. So this is a patient who has a large posterior labrum, severe retroversion with a poorly developed posterior glenoid. So these patients are at very high risk for posterior labral tear instability. Okay.
Is there an ideal amount of retroversion for baseball pitchers?
You don't want retroversion for a baseball pitcher. What you want well, you want retroversion of the humeral articulation, not the glenoid. The change in bony anatomy is in the humerus, not in the glenoid with baseball pitchers.
Okay.
Remember Wolff's Law.
Yeah. Okay. What do you think of this one, Ashu?
This is a 26-year-old with abnormal X-rays and multidirectional instability, and you can see within the posterior humeral head that looks like there's a Hill-Sachs deformity, and there's tearing of both the anterior and posterior labrum. It looks like there's also a bony avulsion of that posterior glenoid. Yeah, it looks like a reverse bony bank right
It looks
there.
like a talus rather than a head.
Yeah, right.
Yeah.
So yeah. So here we have that. This was actually another congenital dysplasia with poor development of the posterior glenoid, leading to instability here, a little bit of retroversion, a small articulating surface, with probably a little bit of a posterior bone injury as well. And then you can see a funny position for a Hill-Sachs injury there.
It would be interesting to X-ray his whole body.
Right. Yeah. So now we can go to inferior labral tears. This is due to inferior dislocation. In this area, you also get HAGL lesions, humeral avulsions of the glenoid ligament, reverse HAGLs, GAGL lesion, glenoid labral articular disruption, and glad lesion, glenoid articular labral disruption. So let's go through, start going through what some of these look like. Michael, what do you think of this case?
I've just seen. Can you hear me?
Yes.
So I'm seeing maybe some mild irregularity along kind of the inferior glenoid. There's a tiny little defect.
Yeah, there. And then if we go to the axial images, it looks like this. This is
Oh yeah, now we can see a linear defect, a little non-displaced posterior inferior labral tear.
Well, yeah, this would be anterior here.
Sorry, anterior.
So that's a primarily an inferior labral tear that extends a little bit to the anterior inferior labrum in this particular patient. Jennifer.
And now we see. Oh, never mind.
Jennifer, what do you think of this case?
Well, here I can see just trace linear increased contrast signal intensity along the inferior labrum, but here on the second coronal images, we see some paralabral cyst formation adjacent to the inferior glenoid. So this makes me, yeah, this is a labral tear.
Yeah. Okay.
And here we have the Aber view.
Right. So this is a labral tear, and one thing that's very common is that these paralabral cysts don't fill with contrast. The reason for that is that this is really a gelatinous structure. It's not really fluid, and it takes a long time for the contrast to diffuse into it since it's a gelatin, not fluid. So it's common for these paralabral cysts not to enhance with gadolinium when you do an arthrogram injection like this. And here's just the Aber view showing the tear there at the anterior inferior labrum, and that's another tear. Here we can see, we don't see the tear very well directly on this particular case, but we can see a large paralabral cyst, which is commonly, which is really a hallmark of a labral tear in this location, some thickening of the inferior capsule. And obviously, when you have a big perilabral cyst in this location, you have to be very careful and look at the teres minor muscle to see whether or not you have involvement of the axillary nerve here with the neural praxis. So there's a tear. That's a quadrilateral placed cyst, and then you'd really want to look carefully at the teres minor. Okay, Ashu, what do you think of this case?
I don't see any images here.
No. So what's the history?
Oh, 78-year-old female with right shoulder pain for 4 months, electric shock-like pain, then weakness, acute brachial plexus, finding an acute brachial plexus injury.
Plexus, right.
Okay, so we're looking at this. Looks like there is a large paralabral cyst extending from the posterior inferior labrum, and it's in the quadrilateral space.
Okay. And what about the muscles?
Muscles, it looks like there's a little bit of edema. I want to say of the teres.
It is the teres minor.
Teres minor.
Yeah, well, I mean,
it looks like the teres major.
In this area, the teres major, latissimus dorsi, this happens to be, if we had all the images, which we don't have to look at, the long head of the triceps muscle location. So, but we can see there is some neuropraxis here due to the big cyst there affecting the axillary nerve and the innervation of the long head of the triceps. And this just, I think in some other lectures we'll go through the anatomy of these muscles down through here, which are a little bit complicated, but this is these are the two of the heads of the triceps coming up here. And that's the nerve that goes to the triceps, and right in there is where the cyst was, which is compressing the nerve, causing a neuropathy in that location. And so this is really the axillary nerve.
And that's a place where you have to be very careful when you operate.
Yeah, right. A lot of important structures there. Okay, Michael, what do you think of this case?
So I'm seeing like there's irregularity along the inferior labrum, and it looks like something's kind of extending into the posterior joint. I don't know if there's like a displaced. And now we can see that there's tear in the extending into the anterior inferior labrum as well.
There's an axial image. It's that.
And then, I mean, that's either displaced labrum or I'm either being tricked out by some foreign ligament.
Yeah, so this is just an inferior labral tear with
a flap. Okay.
Jennifer, what do you think of this one?
Okay, so here we can see these are two coronal images, arthrogram images of the shoulder, and there is some edema-like marrow signal intensity along the superolateral humeral head that looks like could be a Hill-Sachs or at least a recent osseous impaction injury. Okay. And then along the anterior band of the inferior glenohumeral ligament, I don't see a normal connection to the humeral head, so I'd be concerned about a HAGL lesion.
So what do you think happened here? This isn't the typical position for a Hill-Sachs, right?
Most likely this occurred from an inferior shoulder dislocation.
Right. Exactly. This is an straight inferior shoulder dislocation, which is not one of the more common types, with a superior Hill-Sachs and a tear of the inferior glenohumeral ligament, a little labral tear there as well. So this is really an inferior dislocation and a HAGL tear. Right?
Would you do arthroscopy on a HAGL lesion? Jennifer?
I'm not sure for a HAGL lesion, I'm not sure if you'd be able, I think most of them scar down over time, and as long as there's not a large defect in the glenoid, that these can heal without surgery.
Well, you do arthroscopic procedures if it continues to dislocate, because obviously the capsule is quite loose, and it will redislocate on a regular basis. But what I'm trying to say is this area, you don't want to stick an arthroscope in there. It's a pretty dangerous place to put it. So these are done open.
Good.
Thank you for explaining.
And then you attach the capsule to the bone.
And here's another case. Here's another impaction injury. Not as big as the previous one, but we can see this really isn't a HAGL lesion. This is just a mid-substance tear of the inferior glenohumeral ligament. Maybe extends over toward the glenoid, but this is really a mid-substance tear of the inferior glenohumeral ligament. And the other thing is you don't want to put a lot of saline under pressure here like you would do with arthroscopy, because it'll extend out into the axillary area and you can get compartment syndromes.
It won't stay. The hand and the forearm and arm is gonna be look like a balloon.
Yeah.
You might get
Right.
an infarction.
Ashu, what do you think of this case?
Looks like a fracture of the greater tuberosity here. It looks almost like an avulsion with the supraspinatus retracted a little bit there.
Okay.
And there's an injury to the inferior capsule. There's a lot of edema extending inferiorly past the capsule. I think there's a avulsion of the inferior glenohumeral ligament, humeral attachment there, and there's a lot of synovitis.
And then there's a HAGL lesion, but there's more to the shoulder than that. If you look at that, rest of the muscles, look at the abductors, and what you get. It looks like fat rather than a muscle. So this is a old lesion.
Yeah.
The greater tuberosity is pretty mucked up.
Yeah, but this person had an acute inferior dislocation, and for the supraspinatus had a superior Hill-Sachs, and then has a tear, a HAGL here.
HAGL.
But as John said, this is chronic. There's a chronic disease here because you have marked thickening of the inferior capsule.
Yeah, there's also nerve injury, John, I think.
Yeah, so this is acute on top of chronic, and it's probably dislocated because of chronic abnormalities and the lack of adequate muscle control.
Maybe a little too much vodka or something.
That could be true. So why don't we stop here and we'll pick up at this location next week. Okay, any questions?
No, thank you.
Thank you.
All right.
Have a good weekend.
Have a great weekend, everybody.
Ashu, do you have that stat case to go over?